Some of the people on the call have already received logins for this, and the others, this is a visit they can do to see what we do. When you open up the page, it will give you some basic topics, physician advisor basics, but then also disease-specific documentation. That's what we have figured out over the last few years, is that's the best way for education, where we talk about a case, and then we discuss on where the audit points are. We discuss what's wrong with the case. We discuss how we can make it better. And from a physician standpoint, it's always great to have a good and solid medical record. But from a hospital and reimbursement standpoint, it's always great to know that once a rock solid documentation is there, the audits and denials costs are almost down. Most of the cases that we do in these presentations are real cases that we've been doing for some of our facilities. Again, this is all de-identified data, but you'll get the gist of this. Now, a number of topics, say you click on acute kidney injury on the LMS, it should open up a video page, references, PowerPoint slides. The video is a sample recording. We'll be doing COPD today. Pneumonia has been done, acute kidney injury has been done, and our goal is to cover the top 14 to 18 DRGs that are bread and butter for hospitals. So a number of topics that are coming along is changing physician behavior, clinical and regulatory review, and then topics like acute kidney injury, pneumonia, asthmas, and you can see these topics that we have here. Let's move on to our topic of let's start with a regulations versus logic topic. And okay, let's hold on. I think there's some technical issues happening here. Okay, I was told that people were not able to see the screen appropriately. Are you all able to see the screen correctly now? Okay, so let's start with a topic of regulations versus logic. And I want to read this problem out to you, and then we'll see how this makes sense in our whole scenario. So Christina, Tyler, Kayla, and Austin each ate something different for breakfast: waffles, cereal, donuts, and muffins. They each had something different to drink: tea, orange juice, apple juice, and milk. And the question that comes to us is, well, what did each of them eat and drink? So the person who had cereal did not have orange juice. Austin did not have milk. Christina did not have tea. Person who had donuts did not have milk. Tyler did not have cereal. Person who had muffins also had tea. Kayla likes to drink either orange juice or milk for breakfast. Christina did not have cereal. Austin did not have orange juice, and the person who had cereal did not have apple juice. So Christina did not have donuts or milk, Christina did not have muffins and milk, and Tyler did not have donuts. And some of you may be wondering, why are we even talking about this? Well, this is a second grade logic problem for my daughter. And it took me some time to figure this whole thing out. But when I put it into perspective, this is exactly how, if I change the names of Christina, Tyler, Austin, ICD-10, CMS 1599, audits, ACOs, certs, RACs, MECs, ZPICs, HIPAA, all this is what is confusing to physicians. And we can interplace those names by using this, which is how we'll figure out. I'd give you a minute to see, to think about that problem, and then we'll come back onto how this is affecting us. So what we talk about here is this new model of healthcare, and why this is affecting us is there is so much change that's happening. Healthcare providers, quality measures, self-scoring, clinical improvement activities, care coordination, safety, patient experience. I mean, physicians and hospitals are being bombarded with so much right now that it's difficult to focus on the patient as well as on the disease specific that physicians want to know. And from a hospital's viewpoint, they are into performance measures, internal benchmarking, Lean Sigma 6, TQM. They want consistent care that's delivered. And that's where there is a little of a seesaw between physicians and administration. Where we come on is trying to tell the physicians that education is key, but there are financial penalties. They need to participate in the process. We need to give them feedback. And there's also an issue of financial rewards with administrative changes. Now, a lot of you who have been part of the LMS know this slide. And the reason it's in a green, yellow, and red is because the green is the QIOs and certs that actually help us. The yellows are the MACs, MICs, and RACs. Again, these are the compliance oversight, but I think we need to be careful of the ones in red. That is the legal oversight, the Department of Justice, the OIG, the ZPICs, and I think every day you'll be hearing in the news about each of these organizations trying to see whether hospitals are in compliance and are doing the right thing or not. And this also affects physicians, because when bundling comes in, physicians are going to be part of that whole equation. Not to mention insurance companies sending the notice of improper payments and recoupments that a lot of hospitals are receiving for cases that have been done 2, 3, even 4 years ago. So there are some CMS assumptions, and I had to bring this slide up before we start COPD, is because one of the basic tenets of a medical record is the admission order, and CMS will assume all orders below to be billed as outpatient. So if you look at this terminology, admit to ER, admit to observation, admit to recovery, admit to outpatient surgery, admit to day surgery, or admit to short stay surgery, even though the word admit is there, where they are putting to, the place does not matter unless there is an order as admit as inpatient. Everything else is going to be taken as an outpatient. And so the discussions that start with when we do appeals for a number of hospitals is, was there an appropriate admit order or not? If not, then it's outpatient. So then we have to spend a lot of time convincing them that the intent was right. But those are longer appeals, and usually don't get settled in a peer-to-peer, which we can do in a few minutes. Now, there's an article that I had written some time back, and this is a few years back, Red Flags Within Documentation for Hospitalists. And you can always click on this article on the PowerPoint slide that you'll get in the LMS. But the whole idea is it is a medical legal record that cannot be taken lightly. As part of some of our RAC relief group discussions, we know that attorneys are using the copy-paste cases in an EMR and trying to use that during medical legal lawsuits. When last year when ICD-10 started, it affected us because it wanted us to be more specific in documentation. And how this is going to affect us is when we do discuss COPD, you will see there's a lot more that's required. So many of the ICD-10 codes, more than a third, are identical, except they talk about left or right. So it's always important for orthopedics or for cellulitis or for issues where there is laterality. And the whole idea is it can capture this in a more efficient way. So for today's topic, we're going to start with COPD. The other topics that you can see are all part in the learning management system and are going to be discussed in future weeks. So we start with two cases, and just as a reminder, If we look at case 1, there is a patient, a 51-year-old male patient, who comes in through the ER on the day of admission by private vehicle, at which time he was complaining of increased shortness of breath, wheezing, dry cough, and his symptoms were exacerbated by exertion, lying flat, coughing. There's a good chief complaint. The HPI, although not complete, is appropriate. When we look at chief complaint for patient number 2, again, shortness of breath, and again, it describes a 73-year-old female presenting to the office on the day of admission, some difficulty breathing. She'd been given Rocephin, Decadron, Depot, started on Omnicef in the office, but she continued to have increased coughing, significant dyspnea with exertion, unable to ambulate more than 10 feet without dyspnea, had a continuous cough despite Mucinex, using more Pro-Air and Duonebs, given Tessalon pearls, and she was admitted with acute COPD exacerbation with failed outpatient treatment. So just from the onset, you can see the difference in documentation between case 1 and case 2. When we move on to further slides, you'll be surprised at how case 2, which is a patient admitted on a Friday, you'll be seeing how the weekend notes came through, and ultimately both these cases ended up going for a peer-to-peer. So what we'll do is we'll talk about some definitions, some pathophysiology, signs, symptoms, the use of secondary diagnosis, ICD-9 and 10, screening tools, and then some coding tips. And this has been pretty much our standard template that we follow for all our disease-specific processes. Now, having said that, this is not a full, complete education on COPD. It's just the tip of the iceberg on what needs to be in a documentation, in the record on COPD as of right now in the case that you have in the hospital to prevent an audit. All physicians have learned about COPD, all case managers know about what Interqual, what Milliman say, but I think it comes down to putting it as a whole in the picture to describe that we get full payments for it. So COPD, third leading cause of death in the United States, major cause of disability, 12 million people have been diagnosed. And the reason why these numbers are important is because this is a very expensive disease, which is why there's so much effort into trying to find standardized treatment protocols so that there is less variation. And we all know about the GOLD guidelines that have been around for some time. But when the ACP and American College of Chest Physicians had done this excellent study for the GOLD guidelines on 69,000 patients, and as you can see in the percentages, almost all of them had supplemental oxygen and chest x-rays. 97% received bronchodilators, 85 systemic steroids, 85% were given antibiotics, and 66%, that is only 2/3, received the entire set of recommended care processes. So why this is important is there is evidence-based medicine to show that these are interventions that are going to help the patient. Now, when insurance companies send denials to us or when evidence-based guidelines are made, they are all derived from standard medicine textbooks. So whether it's the Harrisons, whether it's Davidson's, whether it's Hutchinson's, nobody creates their own evidence-based medicine. They base it on what literature has been around. So if you have an insurance company denying a COPD because you put that patient in an inpatient without doing an x-ray, without the patient being on home oxygen, requiring either a higher rate of oxygen or no oxygen at all, maybe received only 1 or 2 doses of inhaled nebulized bronchodilators over a 2 or 3 day stay, did not receive steroids, and was given some oral doxy, you can almost see why they can feel that we shouldn't be paying an inpatient level of service for this. So we have the GOLD criteria has been one of the references that many insurance companies use for denials, and it makes perfect sense for someone to have this. We'll talk in the next few slides on how there's some little nuances on using this in the documentation. You can see this slide. In the next few slides, we'll talk about so many organizations are working on COPD. There's the Global Initiative for Chronic Obstructive Lung Disease. They have a World COPD Day. They have their own guidelines, which are available. to the general public. They have a diagnosis and management desk reference. They have an app. They have pocket guides. So there's some teaching slide sets that they've come out with. The American Lung Association has its own set of data for COPD. They have some educational material not only for providers but for patients. And these days, many patients are, have consulted these websites and come to us asking, well, this is what I have. What else should I do? So there are educated patients that are using these. The COPD Foundation had come up with the updated GOLD strategy. And in addition to this, there are some tools to assess symptoms that almost all pulmonologists use. And this is a combination of 3 tools. The first is the modified British Medical Research Council tool, the COPD assessment tool, and then again the CCQ, or the Clinical COPD Questionnaire. Again, all insurance companies are during appeals. This is information that comes out during peer-to-peers almost on every COPD case that we've done. So this is something that the providers, the nurses, the case managers, the nurse practitioners, physician assistants should know about these assessment tools. And how this is put together is it's a very nice tabulation where there is risk on the left side, there is risk on exacerbation history, there is the use of CAT and the MMRC scores, and then it comes down into a staging tool of ABCD. Numerous times we have used this tool to justify that this patient had higher risk and more symptoms. Now, how this affects us today is people who have at least 4 or 5 COPD cases, or hospitalists who have COPD cases today, need to use some of the points in this assessment tool as part of their progress notes. Moving on to the next slide, you can see the range of diagnosis for COPD. And why this is important is simply writing COPD is not enough. You can see this, there is stages of COPD based on FEV1. There is the severity of COPD, mild, moderate, severe. There is COPD with asthma, bronchitis, lung disease. There's a bronchitic component. There's an obstructive component. Why this is more important today is because this is what forms the basis for ICD-10 coding. Unfortunately, if you only write COPD, your coder can only use COPD unspecified, and that definitely is a lesser reimbursement for the hospital, even though that's not a reflection of the intensity of service that you're providing for a case for COPD. So what is the key documentation to support a diagnosis? Well, let's look at these 5 points. So persistent dyspnea following short-acting beta agonists which have been given more than 3 doses, oxygen saturation greater or equal to 92%, or an arterial PO2 greater than 60, continued deterioration despite 24-hour outpatient treatment, mental status changes, and elevated blood sugars. Now, why this is important is this is basic medicine, but these need to form the component of an H&P in a medical decision making. These need to form the component of a progress note on why this patient needs to be in the hospital. Now, documentation, additional one is bronchodilators that have been given more than 6 times in 24 hours, which includes the MDIs with spacers. Corticosteroids. So when in the next few slides, you'll see as long as this patient is receiving steroids, that is appropriate. Oral versus IV, there is no benefit. A lot of people think IV Solumedrol makes the patient inpatient. Unfortunately, no. Just the use of steroids with a preceding history of worsening symptoms is good enough. Oximetry or blood gas. There's been one of the screening tools, and I'm sure the nurse managers on the call would be able to relate to this, requires pulse oximetry at the time of presentation in ER without oxygen. Now, I've been practicing medicine for many years. The moment a patient walks in through the door, with difficulty breathing, they have oxygen on it. If the EMS is bringing them, they have oxygen. So it's very rare that we have someone in acute failure, someone in acute exacerbation having 78 or 70% with the ER pulse oximetry on room air. We do definitely get blood gases, and some of the facilities that we do this have an automatic protocol of an ABG. Again, we have to remember ABG is an invasive test and just doing arterial ABGs on everyone may not be the right methodology. But for COPD cases where you do suspect there is a ventilation perfusion mismatch, ABGs are very, very useful. Now, this is something we all know. Mild COPD, moderate COPD, severe and very severe. Again, this diagnosis has been around for at least 20, 25 years based on the FEV1 versus FVC ratio. FEV1 is rarely used in the emergency room, and someone in acute exacerbation really you won't get much benefit from this. This is to use to monitor therapy on day 2, day 3. Once you've initiated the oxygen, once you've initiated breathing treatments, it's always important to have a baseline, and that's where primary care physicians come in on how to give them a spirometric device for their COPD, useful for asthma as well as for COPD. Now, all of us do a great job in the H&Ps. I mean, those EM endpoints are really done well. It's the progress notes. It's the continued stay. How do we justify on a medical necessity basis? And you need to answer these two questions: is what is this patient's condition that can only be treated in an acute care facility? And then what treatment are you providing that can only be performed in the hospital? So if you have someone with COPD, you know someone requires breathing treatments, oxygen, question comes in is, can this be provided in an alternative setting? If this is someone from the nursing home, can the nursing home not provide this service? That's where your documentation needs to come in, saying there is continued coarse rhonchi with diffuse wheezing despite 6 treatments of DuoNeb breathing treatments on day 2. That gives me a picture saying, well, this patient is sick. Then when we discuss this during appeals, we look at the vitals. If someone is still tachypnic, well, yes. If someone is tachycardic, yes. If there is hemodynamic instability in terms of blood pressure or falling pulse oximetry, when you ambulate this person, that's what justifies a continued stay review. For our case too, you will see some documentation on continued stay, and we'll go on there. So there are some comorbid conditions that go with COPD. There's respiratory failure, there's atelectasis, there's hemoptysis, pulmonary edema, acid-base balances. Pulmonologists are very good in describing respiratory alkalosis, acidosis, respirator weaning or not. This actually gets missed out in a lot of the primary care progress notes. So comorbid conditions do affect the diagnosis, and in one of the slides you'll see it affects actually a lot of reimbursement that the hospital gets also. There are some major comorbid conditions, so aspiration pneumonia, HIV disease, viral pneumonias, acute pulmonary edema, acute respiratory failure. Some of the progress notes you will see have mentioned respiratory failure, but if you don't mention acute, that will be treated as a chronic condition. There is, again, sorry, someone had a question?
I have a question about this. I kind of assume when somebody's breathing 40 times a minute with a COPD exacerbation that they have a respiratory alkalosis because they're blowing off their CO2 or if their VO2 was 50 or 60, or their PCO2 was 50 or 60, that they have a respiratory acidosis. Do we need to code that as a separate diagnosis in our progress note?
If you have an ABG with a pH of greater than 7.35 to the range of 7.45, depending on what the pH is, will guide you into acidosis or alkalosis. Depending what the PCO2 is, will guide you whether this is respiratory. If there's an anion gap, then there'll be a metabolic component. But you need to remember, all acute metabolic derangements have chronic compensatory respiratory issues. So you may have someone in acute respiratory alkalosis just by breathing fast, he's just hyperventilating, but you need to determine, is that from an anxiety or is that someone that just has a ventilation perfusion mismatch from a PE? And again, that's where the whole story needs to make sense.
But you want us to, we should code that or diagnose that?
Absolutely. Because you have thought of that, your treatment is based on that. Having simply written COPD in the assessment and diagnosis doesn't justify or doesn't give a sense of severity of illness to the coder or to the payer. So you do have a patient with COPD, you have someone in respiratory failure, they're tachypnic, they have respiratory alkalosis that you have proven through your labs, you have done everything right. The whole concept is it needs to be written in the record that your thought process for this patient was not the same as a COPD that came into your clinic and you gave them some steroids and some antibiotics.
I have one other question.
Yeah, please go ahead.
From the prior, a couple of slides ago, you mentioned that we needed to document that if they had 6 treatments and they didn't improve. Do you do that in the physical, or do you do that in the plan, or where do you want us to put that?
I think in the progress notes. So when you
How do you look it up?
actually it's so we have access to the EMR for 18 hospitals. There's respiratory therapy notes that I look at for COPD. And in a progress note, if they've been in the hospital for 24 hours, required 6 or 8 treatments, clearly they're not ready to go home. But that's part of the nursing flow sheets, and I know where they are in Epic, I know where they are in Cerner. It's part of the record that the respiratory therapists use. And a lot of times where we end up losing cases is the physician writes lungs clear to auscultation, the nursing staff writes decreased air entry, and the respiratory therapist writes coarse rhoncha and wheezes diffusely, breathing at 22. And that's from a time standpoint, that's where we end up losing cases. Does that help?
Yes.
Okay. Yep. So some of the missed secondary diagnosis, and again, this is a compilation of missed secondary diagnosis that we have found during our discussions in a number of peer-to-peers. And this comes back to one of the questions that was asked is metabolic derangement. So acidosis, RTAs, atelectasis. If someone has a BMI of 56, clearly that means that there is decreased air entry because there's just not enough lung volume to supply that body mass. There is dementia that can affect treatment protocols and safe discharges, encephalopathy, dementias. And the whole purpose of this slide is the story needs to formulate for your progress note saying we had a lady or a male who came in with COPD, but this is the other risk factors that we were dealing with on day 2, on day 3, on day 4 that prevented us from either discharging this patient or that prevented this patient from receiving the adequate treatment because there were these secondary diagnoses that complicated this patient's care. Now, screening tools in terms of whether it's Milliman or Interqual, this is from one of them, and if you see persistent dyspnea, oxygen to maintain sats greater than 92%, they also talk about breathing treatments of more than 6 and 24 hours, steroids and oximetry. So Milliman and Interqual did not create their own screening tools. They have actually pulled it from evidence-based medicine, from Harrison's, from Davidson's. It's just the application. They will try and use this at the time of presentation. They'll use it on day 1, on day 2, to tell you, well, now this patient is well or not. Now, they have talked about ABGs also. So there's a PCO2 level of 45 to 54. There's a PO2 level, there's a pH, and this is exactly what one of our webinar attendees had asked is, do we have to write this or not? The portion that, the part that I look at is, it's part of a screening tool that our payers are using. You already know this stuff. You're using this data to make your judgment on the severity of illness. Let's put it on the record that you thought of all this, and based on this, this is what your treatment methodology was. There is one that they use is persistent respiratory distress and no response to treatment. So if you are on day 2 or day 3 of an acute exacerbation of COPD pneumonia, you have them on IV steroids, antibiotics, and yet they are still tight and wheezy, that's where you need to start wondering, is this patient at baseline or is there something else going on? and whatever your thought process is for our physicians, we need to put that in so that 3 years from now, when they ask us, well, Ms. Jones, on day 3, all you've written is COPD exacerbation, we'll just pay you for the first 2 days. And that has been happening pretty much on a more frequent basis, is they are not denying the DRG of COPD, they are denying the secondary diagnosis on day 2 and day 3. They're just saying, we agree this patient was sick, but we think based on what we saw in the record that after day 2, there was just not enough documentation to support a hospitalization. So we'll pay you for 2 days. We'll pay you an inpatient COPD 2 days. We're just not going to pay day 3 and day 4. And I know this because we are appealing those cases for some of the facilities right now. That's the new strategy that they're doing. Screening tools talk about respiratory failure, BiPAPs with high flow oxygen, complications. Now, it could be complications of treatment, hemodynamic instability. Number of times, if the vitals, a lot of the EMR records and progress notes have these pre-filled boxes where you can put vitals normal, chest examination normal. Clearly, once you put everything as NAD or normal, it means that you have examined this patient and you didn't find anything abnormal. Then whatever you write in your assessment and plan really makes no difference, because the physician or the peer reviewer is saying, well, the examination is normal, you put in there are no complaints, what are we looking at? Now, some physicians confuse this with EM coding, where only 2 out of 3 are appropriate for an EM code. But when we're doing this for medical necessity justification, every part is appropriate, so that on a SOAP note, writing COPD stable doesn't do justice to that SOAP note if it's on day 2 or day 3. So what doesn't count? IV steroids and oral steroids have similar efficacy. One of the screening tools does talk about IV steroids, but from a patient standpoint, 60 milligrams of IV Solumedrol every 6 hours for 2 days, that is a lot of steroids. I'm not surprised that these patients end up having steroid myopathy and then get readmitted within 30 days. So very careful to titrate IV steroids. Usual protocols for COPD, there's an ER shot of 125 milligrams IV Solumedrol, and usual orders are Solumedrol IV 60 every 6 hours or every 8 hours. Now, if this patient is improving, you can de-escalate therapy. That's completely appropriate, that's safe, that's the right thing to do. Another question is IV antibiotics. That does not mean inpatient. Again, screening criteria may push you into using IV antibiotics, but they do not mean inpatient always. Sometimes people are using these 5th generation cephalosporins, IV Teflaro. I had one medical director ask me, why are you on 5th generation cephalosporins? That is the biggest gun that's out there. Things that can, and if it's just COPD exacerbation with bronchitis. So unless there is a healthcare associated pneumonia component where you want to use vancomycin and zosyn, whatever you use, we don't make a judgment call on the IV antibiotics. Sometimes that does help. If you're giving IV gentamicin for someone with Pseudomonas, and the dosing is every 8 hours, and you have said we'd want to keep this patient in until we have 72-hour blood cultures because this patient has high risk for recurrent COPD, and there's a cystic fibrosis component with a Pseudomonas component. Any story that is out of the ordinary, and you have made a game plan for that always wins on these appeals. Some people use albuterol, some use Atrovent, some use Duonebs. Either one of them is okay, as long as you're using something and you are showing, and a lot of time respiratory therapists do document improvement in clinical respiratory exams after treatment. So that's something that we look at. That's something that auditors also look at. Some people on COPD are on home oxygen. And if someone's on 4 liters of home oxygen and now they're on 3 liters, simply by that objective criteria of 3 liters of home oxygen, that doesn't count. It needs to be higher than what their home usage has been. And that's something that a lot of us have talked about. Discharge on 2 or 3 liters, and then the question comes in, well, was this patient on home oxygen? What was the flow rate at home? And if it's significantly higher, that makes a much stronger case. So we have a hospital reimbursement for a 250-bed hospital. This is from CMS, and they did a DRG of 192, simple COPD, I think a 3.5-day stay. This patient did have CHF at one point, but they ended up writing CHF, and the hospital got a reimbursement of about $8,300. Now, same patient, but the hospitalist decided, I've looked at the echo from 3 months ago. This patient has an EF of 35%. They have an AICD, and the secondary diagnosis is systolic heart failure. Same patient, same COPD, but the DRG changes to 191 with comorbid conditions. The hospital gets about $10,700. Now, let's look at scenario 3, where same patient came in dry, was hypotensive. You gave this patient some fluids. You know this patient has an ejection fraction of 30%, AICD, and 24 hours later, this patient is in heart failure. Well, then if you write secondary diagnosis, acute on chronic systolic heart failure, and while the primary diagnosis is acute exacerbation of COPD with or without bronchitis or pneumonia, whatever your imaging shows, the hospital gets paid $11,000 for that. So there is a huge difference on what you write in terms of severity of this patient. Again, respiratory failure with pulmonary edema, that's a different DRG, but that's about an $11,000 average payment. Most of these patients stay in the hospital for 2, 3, or even 4 days. But where the insurance companies start to ask questions is, what was the impact of the secondary diagnosis on day 2 or day 3? And that's how they start saying, we'll pay you for the COPD, we'll pay you for the CHF, we're just not paying you for the acute exacerbation because you haven't documented that. Your progress notes are saying lungs clear to examination, there's no JVD, there's no pedal edema. So you just haven't justified the acute exacerbation of CHF. And that happens on a pretty regular basis now. So you can see for a 250-bed hospital, that same, they had about 98 discharges for simple COPD. They had 148 for comorbid conditions, and they had 82 for without the comorbid and major comorbid. They had a total of 328 admissions for that 1 year total discharges. There was the average payment has been listed, and the total payment for just COPD without comorbid or major comorbid conditions was about $1.8 million for that one hospital. And they had, I think they had about 8 hospitalists. So this was divvied up among them on the total reimbursement. Now imagine COPD is just one of the 18 DRGs that is bread and butter for this hospital. That was a lot of money that was at stake in terms of appropriate documentation and then clawback and recoupment. Again, we come back to this, and again, anyone who's been on the LMS looking at these presentations knows that this slide comes on, and again, what is the condition that can only be done in the hospital, and what is the treatment that you're doing that can only be done in this acute care facility? That's something that needs to be answered every day, independent of the H&P. When you look at ICD-10, these are just some more specifics that your coders will be sending you, these blue slips or green slips. I know Epic can have these sticky notes that come up with queries, and a lot of times, the queries are very specific. Did this patient have an acute exacerbation, or was this compensated? So simple things, but again, important in terms of reimbursements. Having done the EM audits, the ICD-10, I think the question comes down to is, what are those pre-existing medical problems, or what are those extenuating circumstances that make the admission of the beneficiary medically necessary? And a lot of the QIOs, they're on hold for reviews right now, but this is part of the education that they're getting, is you can look at screening criteria, you can look at documentation, but you need to be answering this question. Again, Medicare wants their beneficiaries to get the best care, but at the same time, they want to make sure that if they're paying a facility, well, the facility and the physicians are doing a good job in documenting this exact statement. Why is it medically necessary for us to keep this patient in the hospital? And a lot of us had been part of the Open Door Forum from CMS. I think there was a huge snowstorm that happened, and there was a curfew that one of the states had put in. Patients were not allowed to be discharged, and in the Open Door Forum, a physician colleague had asked, well, it was a government curfew, a federal curfew for that state due to a weather-related event. The patient crossed the second midnight. Can we now bill inpatient? And as CMS, they took probably about 2 seconds to think about it, and 4 of them said in unison no, that was due to beneficiary inconvenience in terms of time and money. We do not think that was appropriate. Now, whether that was the right thing for the hospital to do, to keep the patient in when there's a snowstorm and there's a curfew, absolutely yes. Should they have been paid? Now that's where CMS says, well, it wasn't medical necessity, but that's where we talk about in peer-to-peers is, how did you expect us to let someone go, an 80-year-old female be discharged to home at 8 p.m. when there's a curfew outside? And we did 2 of those cases that we just completed 2 weeks ago. The medical director did agree with it. And he says, it's not the rule, but that was the right thing to do, and so we'll grant you that. That rarely happens if it's because the patient's family is outside and can't make a decision, or you can't locate a son, or the daughter from California needs to now come in and it's going to take her 2 days to make that decision. So documenting this, in this particular case, we were successful. We're not always, if it's a reason for just beneficiary inconvenience. So this is our case 1, our 51-year-old. We put in ER, coming through the ER. There was shortness of breath, wheezing, dry cough. There's some good vitals here. There's tachycardia with a heart rate of 110, tachypnea with 22. BMI isn't too bad. There's documentation saying there's moderate respiratory distress upon presentation. And then the respiratory exam is wonderful. There's respiratory distress, wheezing, prolonged expirations, accessory muscle use, decreased air movement. I mean, this, I don't think someone can get a better examination documented than this. And they've talked about some blood work. There's an ABG, there's PCO2s, the oxygen saturations are 88%. And they talk about acute exacerbation of COPD, bronchospasm, hypoxemia, acute respiratory distress. So this is one of the easy ones. I think when the medical director and us looked at the case, it took about 2 minutes for him to say, well, we made a mistake on this one. We'll grant you this as an inpatient. Now, in the same phone call, we had one of these follow-ups, and I had to cover this. And this is an exact progress note that was day 2 on one of the patients. He's doing well. He doesn't have anything new or different going on. Vitals look good. Intake output look good. On the exam, this is the 2 line that I see. Well-developed male who's really doing quite well. Chest, he still has some wheezes here and there, but good airflow bilaterally. PE is otherwise unchanged. Assessment COPD exacerbation improving. We're going to decrease Solimedrol 60 IVQ8. And then the notation on this was some other doctor was going to follow this patient over the weekend, and I'll see him back on Monday. So this progress note didn't do well. The insurance said, we'll grant you the inpatient for the 2 days, but this is day 3 follow-up. This seems like there's really nothing going on. There's hemodynamic stability. Nothing in this gives us the impression that this patient still needs the hospital. In our second case, they did a great job on Friday documenting how sick this patient was. But let's look at a Saturday and Sunday note. And you can see this is from April 2016. I'm going to read this. COPD improving, no complaints. Continue current treatment, antibiotics and PO steroids. 410. Seen today, no complaints. COPD improving, okay with antibiotics, and I'm assuming ST is steroids, and this is one where they wanted a sniff for this patient. So we just can't get anyone to approve these 2 days of stay as medical necessity. And I think everyone on the call can look at, it's difficult for a payer or any auditor to believe that there was medical necessity based on this. A lot of the home oxygen issues, again, there's NCDs for that, there's LCDs for that. So again, we don't have to reinvent the wheel in terms of education on that. I think simply knowing the existence of these and using them when you do need to keep someone in the hospital and get home oxygen for them. I think there's some beautiful criteria that CMS has listed, and it's on the cms.gov website. I'm not going to read this busy slide, but it pretty much talks about those criteria that any insurance company or any payer will see if someone needs home oxygen. And again, I come back to this slide again and again for COPD. Breathing treatments, oxygen, clinical status after treatment, mental status changes, electrolytes, all need to be part of that documentation to support the diagnosis. So when I did this presentation for a hospital some time back, one of the questions they asked was, what did Christina, Tyler, Kayla, and Austin each eat? And took me some time, but you can see this. I hope this page moved forward for you. Yes. So you can see Christina had a waffle and orange juice, Tyler had muffin and tea, Kayla had cereal and milk, and Austin had donuts and apple juice. All these links have been accessed a few days, and these are all working. People who have access to the LMS, they'll have access to these real-time links. But this is pretty much where we are. Questions from the group?